Hello and welcome to today's webinar, an update on breast cancer pathology. I'm Estelle Dish, Secretary for the Board for the Massachusetts Breast Cancer Coalition. And I'd like to thank you all for joining us today. Massachusetts Breast Cancer Coalition is dedicated to preventing environmental causes of breast cancer through community education, research advocacy, and changes to public policy. I am pleased to welcome today's speaker, MBCC's medical advisor, Dr. Michael Misalak. Dr. Misalak currently serves as Associate Chair of Pathology at Newton Wellesley Hospital in Newton, Massachusetts. He is the Medical Director of the Vernon Cancer Center, the Chemistry Laboratory, and Point of Care Testing. He practices in all areas of pathology in a busy community hospital. He holds an academic appointment at Tufts University School of Medicine, where he regularly instructs medical students and pathology residents. If you have questions for Dr. Misalak after his presentation, please put them in the chat and we'll get to as many as time allows following his presentation. Welcome, Dr. Misalak.
Thank you very much, Estelle. It's a pleasure to be here. I appreciate the opportunity to present to folks and share the good work that the MBCC does, and also let viewers and listeners in on some behind the scenes news and updates from pathology. Pathology is not a specialty that many patients get exposed to. However, saying that, pretty much everybody touches a pathologist whether they know or not. If they come into the hospital, get a blood test, go to the operating room for a biopsy or a lumpectomy, it's the pathologist that's the first one to see that tissue, analyze it, come up with the diagnosis, and get the whole care algorithm plan in motion. It's really the pathologist's diagnosis that determines outcome, prognosis, and even treatment. And what I want to spend the next hour is going through some of the line items. If any of you have seen a pathology report, you either have had breast cancer or there's a family member that's had breast cancer and you've asked to see a copy of the pathology report, and it can be quite lengthy, filled with a lot of long words, difficult sometimes to understand. I'm going to try and break that down and glean out the salient features and give everyone some insight about what each one of those means, why we put it in the report, and why it's important for you to know about it and to become educated. I'm a firm believer that the best patients are those who are most educated about their illness and can ask smart questions and be a team player in the decision making with the care team. You want to be an advocate for your health. No one else is going to speak up for you, so make sure you're well educated about the right questions to ask. And we as doctors love questions, so don't ever feel like any question is not a good one or not worth asking. Guaranteed somebody's thought of that question before and asked it, so definitely go ahead. I'll jump right in here. Oops. Sorry. Okay, everybody should see my screen now. Your pathology report. Some of you may not have known this, but there was recent legislation that was just passed called the 21st Century Cures Act. And what that entails is that you as a patient are now privy to your entire medical record. You had been in the past, but sometimes certain things had been withheld or behind a firewall. You may not have been able to see all the information in your pathology report. Because of this recent legislation that was passed, you now can see everything in your medical record. You can see office notes, you can see consultations, lab reports, x-ray results, anything that's in the medical record is yours. What I want to focus in on is your pathology report and look at some of what we call prognostic or predictive factors, meaning what is it in that breast cancer report that gives important information to the oncologist, to the surgeon, to the radiation oncologist, to you as a patient, to the entire care team about what that element in the report means. Is it something good? Is it a favorable characteristic of the tumor, or is it something that's unfavorable? Is it something that's going to determine therapy, give a choice of therapy, or give some prediction of odds of a tumor recurring, coming back, or progressing? And we'll try and go through each one of those. And as I go through here, if you have questions, just type them in the chat. And as Estelle said, we'll get to them at the end of the presentation. I'll try and leave about 10 minutes for folks to ask their question. The first most important feature is the histologic subtype. And what that means is the type of breast cancer. Breast cancer is not just one disease, it's many diseases. And the pathologist will make a diagnosis, and that should be the first line on the report. It'll say invasive ductal carcinoma or invasive lobular carcinoma. Invasive means the tumor has the capacity to invade through the tissue and potentially spread into lymphatics, the bloodstream, and travel to other parts of the body. That's in contrast to an in situ cancer, or what we call a ductal carcinoma in situ, or a lobular carcinoma in situ. The two main categories of breast cancer are ductal and lobular. I'll show you what those look like. Here's a shot of an invasive ductal carcinoma, and the entire screen here is tumor. These little ducts that I'm highlighting here with my cursor, that's an individual tumor gland, and it's forming this round circular donut-like structure with a lumen, with a channel inside of it. You'll see another one here, and all of them have varying degrees of these donut figures. Some are well formed, some are more elongated, streaming out. Others are just small clusters that don't really form a nice lumen. There are certain, we'll go to the next major type. This is an invasive lobular carcinoma. Now you can see this grows differently than a ductal cancer, but is still a invasive breast cancer. Instead of forming the little tubules and donut-like structures, rings, this grows in cords of single cells and clusters of cells. So you'll see that there's no real lumen formation here. And here's one higher power view that the tumor cells tend to stack up and stream out in this linear array, very characteristic of a lobular cancer. Those are just two types of invasive cancer. You'll see here under the invasive, ductal invasive carcinoma of no special type, and then lobular is also down here as well. But you can see there's many types here, and it's the pathologist's job to put the specific diagnosis on the lesion, and this is one of the major factors that sets the treatment plan in effect. There are certain subtypes that have better prognoses than others. Tubular carcinoma is generally considered to be have a good prognosis because, as we'll see next, that goes into the grading of cancers, and we'll talk a little bit about that. A pure mucinous carcinoma also tends to have a little better prognosis. The next thing we'll do, once we characterize the tumor as this is an invasive cancer or it's an in situ cancer, is we'll score it or put a grade on it. And the accepted scoring system is called the Nottingham score, and that should be listed somewhere in the pathology report. And what that is it's 3 elements that the pathologist looks at under the microscope. One is the degree of which those tumor cells are making those little rings, those lumens. If there's a lot of them, the tumor is considered well differentiated because it's trying to recapitulate normal breast tissue as closely as it can. And that's sort of the way to think about grade, is how closely is that tumor resembling normal tissue. If it looks like it's trying to form normal tissue, it's got a lot of those ring structures, we'd say it's well differentiated. That would be a score of 1 for the tubules. Now, each characteristic goes from 1, 2, or 3. The next characteristic that we look at, so this is a higher power view of that first cancer that I showed, the invasive ductal carcinoma. You can see it's forming a lot of tubules. So this would probably be a score of 1. Now that's in contrast to something like this. This is another tumor, and you don't see any of those tubule formations. It's solid nests of tumor cells growing in clusters. It's invading fat. These soap-like bubbles are fat, so it's growing out from the ducts and the lobules of the breast into the surrounding fat. This would be a score of 3. It's generally going to be a more poorly differentiated tumor, and that has certain characteristics. The Nottingham score, we will add it up. We'll look at the tubules. The next thing we look at is the characteristics of the cells, the individual cells. How, quote, different from normal do they look? Are they, quote, ugly looking? Do they look very bland or banal? Or are they pleomorphic, meaning they have different shapes and sizes? And you'll see here there's a big cell here, another big cell, variety of smaller cells. There's a lot of variability. The other factor which goes into the Nottingham score, so we've got tubules, the cell appearance or the pleomorphism, and finally the mitotic count, which is a mitotic figure is a cell that's in division. And right here in the center is a mitotic figure. This is one cell that's dividing. And it's an indicator of the growth rate of the tumor, the turnover potential of the tumor, how quickly that tumor is growing. So it would only follow naturally that if we see a lot of mitotic figures, we assume that tumor is growing quickly. It has a high turnover rate. It's metabolizing quickly, so it has the potential to grow and spread more quickly. Those 3 factors, the mitotic count, the appearance of the cells, and the ability to form tubules or not, we add those up, and what we get is a Nottingham score or grade. Lower numbers are well differentiated. Higher number would classify as a poorly differentiated tumor. And then it's of course a spectrum. In the middle, tumors are called moderately differentiated. Higher grade tumors are associated with more aggressive behavior. They often will have a shorter time to recurrence or progression. The flip side of that is, interestingly, even though it's a poorly differentiated tumor, they often will respond better to neoadjuvant chemotherapy. And we'll go into that a little bit later. But what that is some breast cancers are amenable to surgery up front. Others, depending on the characteristics of which we're going through, may warrant giving some chemotherapy first to shrink it down, to de-stage it, to bring the stage down. And we'll talk about stage as well in a bit. But sometimes patients may be treated with chemotherapy in the hopes of shrinking the tumor to get a better surgical margin, to get a better clearance, to be able to completely excise that at surgery. Which it's one higher power view showing a mitotic figure here. There's actually another one right here, and you can see there's a lot of variability. These are all tumor cells, this entire field. This goes right into our next characteristic that's important in the pathology report is the size of the tumor. Larger size at diagnosis is associated with long-term risk of recurrence. It's also associated with survival. The way tumors can be measured in a variety of ways. The first measurement that a patient may hear about is that which is derived off of a mammogram or an ultrasound or even a breast MR. An imaging study may on the report say there is a 1 centimeter ill-defined nodule, or it could even be palpated. So there's a number of ways in which a tumor can be measured. It could be palpated, it could be seen on imaging. Really, the gold standard, though, is after surgery, when we look at that specimen here in the lab or even under the microscope here, is we will do a measurement as well. We'll try and correlate it to make sure we're seeing what was seen radiographically, but the size that we get pathologically is really the size that's going to go into the staging of the tumor. When we talk about stage, there's 3 factors, again, just like when we grade a tumor. When we stage a tumor, we're looking at 3 different characteristics. So we're looking at size, and that's what I'm demonstrating here on the screen is T. That means tumor size. The staging system that's in use across America and the world is called the TMN staging. T for tumor, N for nodal status, and M for presence or absence of metastases. And I'll go through what each of those means as we proceed through the presentation here. But basically, we'll measure it in millimeters, and we'll see, is it less than a millimeter? First of all, is it all in situ and not invasive disease, which would be a TIS, in situ? Or is it microinvasive? That would be a really small tumor, less than a millimeter. Those that are 1 to 5 millimeters are 1A, 1B is 5 to 10, 10 millimeters is a centimeter, 1C is 10 to 20, 20 to 50 is a T2, a T3 is greater than 5 millimeters or 5 centimeters. And then after that, we stop measuring, because then we talk about local growth of the tumor. Does it extend to the chest wall? Is it causing changes to the overlying skin? Or is there some sort of inflammation? Is it into the lymphatics of the skin? And then we get into T4 tumors. As I mentioned, stage, size, larger size at diagnosis, not unexpectedly would be associated with a lower risk of, a higher risk of long-term recurrence. Another very, very important piece of information to get out of the report is the lymph node status. Potentially, there may have been a lymph node that was seen radiographically. It could be biopsied during the initial assessment of the tumor, or it could be taken out during the lumpectomy or mastectomy procedure in surgery. The reason we look at lymph nodes is lymph node positive cases are substantially worse in all breast cancer subtypes. So that's one key element that is going to be a driver towards therapy, towards prognosis. It's going to be predictive, and it's also prognostic. When we talk about lymph nodes, the lymph node system are nodes scattered throughout the lymphatics. The lymphatics run pretty much parallel with the vessels in your body, and they serve as filters of invaders in the blood, bacteria, foreign elements, and even foreign elements meaning tumor cells. Your lymphatic system is composed of lymph, which is the medium through which lymphocytes flow through these channels. Here in the image that I'm showing, you see lymph nodes in the axillary region and then sort of around the breast. They're connected by lymphatic vessels, and this is a circulatory system, just like the arteries, veins, and capillaries of the system of your body. The lymphatics are all interconnected and serve to filter. And in the breast here, what we now do several decades ago, we didn't understand the whole concept of how the lymphatics function, and when somebody would have surgery for breast cancer, the surgeon may go in and do a full axillary dissection and try and take out as many nodes as possible in the axilla here, in the attempts of identifying any metastases that weren't palpable or evident radiographically. That at the time was thought to be standard of care. We realized that that's also associated with a lot of morbidity, meaning women were unfortunately developing a lot of edema in their arms after those procedures because, as you recall, this drains lymphatic fluid. If we interrupt that system, there can be problems with the drainage of lymphatics, and there can be swelling as a result of that. So what we now do is we've recognized that there's something called the sentinel lymph node, which a sentinel is like a sentry in an army. They're on the lookout. They're standing high above a wall looking out for foreign invaders. And that's typically the first lymph node that receives lymphatics from the tumor region. And the way that we find that is we will inject a radioactive substance or a dye nearby the tumor, wait some amount of time, then the patient will go into the operating room, and during the operation, the surgeon will use a probe to find where that lymph node is, where it took up the dye, and they'll both see it, and they'll also be able to detect it with the probe with a small amount of radioactivity. Sometimes it's one lymph node, sometimes it's a couple, but the concept here is that if there's any tumor spread from the tumor into the lymph nodes, the first ones it's going to get to are the sentinel nodes. So if we look at those within the OR and determine they look normal, there's very, very little likelihood that it's gone beyond that, or that it's skipped over that and gone to a non-sentinel lymph node. So the surgeon will take those out. The pathologist will often look at those in the operating room, and then a decision can be made about whether the patient needs further removal of lymph nodes. That's the concept of sentinel lymph nodes. Staging, as I mentioned, starts with the T, then the N is the lymph node status. Did the pathologist find any lymph node metastasis? If not, it's an N0. If we see them only with the use of some special stains under the microscope, we may call it as an I negative or an I plus. I'll get into that. And then if there is a positive lymph node, we measure it. Is it very small? Is it just less than 2 millimeters, of which case it would be a micrometastasis, or is it larger, greater than 2 millimeters, and then it would be an N1A, B, or C, depending on what type of lymph node it is. And then once the metastases get bigger, you can see, or it's involved in more lymph nodes, then the staging will go up to an N2, N3, A, B, and C. So that's another very important element to look at in the pathology report. We will always state it in there as well. Margin status, also very important in the pathology report. And margin status really only comes into play after surgery. When a biopsy is done during the diagnosis, we're not really worried about margins. It's just a stereotactic needle biopsy, taking a small core of tissue out. We're just trying to identify what the lesion is. Then if we diagnose a cancer, the patient will then be considered for surgery, possibly a lumpectomy or a mastectomy. And when that tissue then comes out, now we look at the margins. We want to see if we're looking at this, this would be a negative margin. Here's the tumor, here's normal breast tissue around it, the edge, this is the margin, and this would be a negative margin. A positive margin is if the specimen comes out and we find that tumor goes right up to the edge. And how do we know that? We will ink the specimen. When the specimen comes out, we'll put a colored ink around the specimen, not just one color, but we'll use 6 colors on all different sides so that we can orient it and we will know, okay, the tumor here touched black ink. I know black is posterior, so I can tell the surgeon that the tumor extends to the posterior margin. You may notice on your path report that there's more than one specimen. The trend nowadays is to do a lumpectomy and during the same procedure, take separate margins around that specimen, what we call shave margins. So instead of taking one large lumpectomy in the efforts for breast cancer, breast tissue preservation, breast sparing procedures, we'll try to take as little as possible. So we may do a lumpectomy and then do some shaves around that. So these separate shave margins would be the true margins that we look at, and then try to put it together as a puzzle and be able to tell the surgeon definitively how far away the tumor is from those margins. Margin status, obviously a positive margin is associated with higher local recurrence rates. For invasive cancer, for DCIS, ductal carcinoma in situ, we try to keep it at 2 millimeters. Some surgeons are content with no ink on DCIS, meaning it could be less than 2 millimeters to the ink, as long as it's clear. But that's something that's locally best determined with your specific care team, what their practice is. But generally, we strive for negative margins, both for the invasive cancer and any associated DCIS, which brings up DCIS. That's ductal carcinoma in situ. It's thought to be the precursor to an invasive cancer. And this, under the microscope, looks a lot different from invasive cancer. First of all, it's being confined by the ductal system within the breast, meaning there's a membrane around this, a continuum of cells that keeps the tumor in check. It hasn't broken out into the surrounding tissue, so theoretically there is not access to surrounding vessels and lymphatics with which it could gain metastatic potential. In situ disease theoretically is completely curable, 100%. It does not have the potential to spread or metastasize, and often it will create calcifications, which I'll show you, and that's one of the indicators of potential DCIS that will be seen on a mammogram. The radiologists can differentiate calcifications that are associated with DCIS versus those that are associated with benign processes. This is one look to DCIS. This is what we call a cribriform pattern. It has this sort of sieve-like complex sort of three-dimensional look. This material inside this big dilated duct is all dead tumor cells that are sloughed off in the middle. Here's a little higher power view. Very much like we grade an invasive cancer, we will also grade ductal carcinoma in situ, looking at the same nuclear or cell morphology. This here would be an example of a high-grade ductal carcinoma in situ. Here's another shot of another pattern of ductal cancer, and you can see we can generally draw a circle around it and show that it's well contained, it's well confined, it's not invading or infiltrating haphazardly. These clumps of black staining material, those are calcifications, and we will sometimes see calcifications associated with DCIS. Here's yet another pattern to ductal carcinoma in situ? It could be growing in a papilloma, it can have this sort of complex papillary type structure, or even more of a tufted micropapillary look. So there's a variety of different patterns that we as a pathologist will grade and subclassify the DCIS. It's important to look at that as well. That's graded just like an invasive cancer. One higher power view of more DCIS. The one factor that's we generally will report nowadays, where in the past hadn't been recognized, is the concept of extensive intraductal carcinoma, or EIC. This is something that we'll try to look for in a lumpectomy or mastectomy. And what it is here's two figures illustrating, if this is the invasive cancer here, this irregular stellate mass, and what's circled here are foci of DCIS. Extensive EIC, or extensive DCIS, is where DCIS comprises more than 25% of the whole tumor volume. It occurs both within the tumor and outside the tumor here. It can also be classified if you have a small tumor and it's dominated by DCIS. That would still be a case of EIC. And the reason why we look for that is it's associated with local recurrence where the margins are close. So once again, underscoring the importance of margins, not just knowing there's DCIS present, it's a negative margin, but what is that margin distance, and was there EIC there or not? That is going to be something that's really important for the oncologist to know about, the radiation oncologist. It may offer more reason for a patient to need some adjuvant chemotherapy or radiation therapy after surgery. LVI, or lymphovascular invasion, is another characteristic that should be in all pathology reports, both the biopsy and any subsequent excision or mastectomy. It's a feature that we look for, and what LVI is going back to that image of the lymph nodes centered along the lymphatic channels. If we have a tumor growing, first it will start out as in situ, has no metastatic potential, no ability to reach lymphatics or vessels to spread. If left unchecked, that can grow, proliferate, and eventually break through that basement membrane that I talked about, that border that's holding it in. Once it does so, then it potentially has access to vessels. Those vessels can drain into larger vessels. So there's proliferation of the tumor, invasion. It can go into the vessel and then survive, circulate, and go to other regions of the body. The lungs, the liver, bones, the brain, really anywhere that blood vessels flow, a tumor embolus could wind up. It doesn't always mean that every tumor cell that gets out into the blood is going to seed a distant organ and grow into a new tumor. There are a variety of factors along the way that impact the survival of those tumor cells, whether they can get out of the blood system. They may die. They could lay dormant for some amount of time for some reason, then enter back into the cell cycle, proliferate, at which some could die again. But if those then continue to proliferate and turn into a tumor, that's what we call a metastasis. This is what we're trying to prevent with early detection, early intervention, early treatment, early surgery. And this is something we look for under the microscope. Do we see cells that are beginning that process of invasion, of just in this early phase of like stage 3 here of invading into the vessels, not yet gotten to distant organs or even grown into anything substantial. We're trying to look to see, do we see the earliest signs that this tumor has some propensity to try and travel to distant organs or not? And why is that important? LVI is associated with local recurrence. After treatment, it has a higher risk of having a positive lymph node. It may be something that the surgeon will take into account if they see on the biopsy that there's LVI present. There probably would be a higher likelihood that they may want to do a sentinel lymph node or have a low threshold to even do a more formal lymph node dissection to try and detect any early lymph node metastases. The next thing we do as pathologists when we're characterizing the tumor, and we do this in all breast cancers, is we determine its estrogen status. That's ER expression, estrogen receptor. We look at 3 biomarkers, estrogen, progesterone, and HER2. I'll go through each one of them. These are major predictors of outcome. ER negative tumors generally have more aggressive behavior, shorter time to recurrence and progression. I'll show you what that stain looks like. In contrast to some of the images that I was showing you before, where we see varying shades of blues and reds, purples, this is a brown stain, and the estrogen receptor is located in the nucleus of the cell. So the stain preferentially localizes to the nucleus if there's estrogen expression by that cell. And this is a example of an invasive breast cancer that is estrogen positive or ER positive. The pathologist recognizes the brown staining of the tumor, will generally score it, what percentage of the cells are staining positive, generally greater than 1%. So we will look for if not much is staining, we make a really hard effort to try and find any staining. We want to give any benefit to the patient because ER positivity opens up the option of another treatment arm for that patient. They can potentially be offered tamoxifen or an aromatase inhibitor versus ER negative tumors, which generally won't respond as well to estrogen therapy. Progesterone expression, PR, is progesterone receptor. That's another line item in the report that should be there. Is it progesterone positive or negative? Just like estrogen, it's a stain that localizes to the nucleus. The progesterone receptor is in the nucleus, and we look for positive or negative staining there. Progesterone doesn't have as much of significance to the oncologist, to the care team, as estrogen. Estrogen is really the driver here. Is it an ER positive tumor or an ER negative tumor? There are some circumstances in which we will assess the progesterone status, particularly if it's an ER negative tumor. We might want to look at, was there a problem with the staining? Why wasn't it ER positive? It can serve as an internal control for that reason. It does have some prognostic significance as well, very similar to ER. HER2 is another biomarker that we will assess on all invasive tumors. That, in contrast to the ER-PR, is a protein that's found in the cell membrane. So when we stain cells for it, we're not looking for nuclear staining, but we're looking for membrane staining. So you'll see here, tumor cells are being highlighted with a nice circumferential brown ring of staining here. This is an example of a HER2 positive tumor. We grade these in varying, we look at the intensity, how much of the cell it's staining. It can be HER2 negative, it could be 1+, 2+, or 3+. This is an example of 3+, it's intense staining. And why is this important? In recent years, we've developed a whole arm of therapies that are directed against this HER2 receptor, which is a growth receptor for the cell. And if we can interrupt this is showing that this tumor is largely dependent, being fed by HER2 receptor pathways. And if we can interrupt that, we can potentially make a big impact on treatment and stopping the growth of this tumor. So HER2, another very important feature. You want to look for that in all path reports. It really is the standard of care to have that reported, and you should ask questions if you don't see that in the report. Proliferation index. This is another criteria that some centers will report, not all centers. It's not universally accepted, but you may see it in a report. And what that is, it's a surrogate marker for the mitotic count that I talked about earlier. This is also a nuclear stain, and it's highlighting cells that are in the process of dividing. Either they're getting ready to divide, they're dividing, or they've just finished dividing. So they're actively cycling. And sometimes it can be a little bit more sensitive than doing a nuclear or a mitotic figure count. Some centers will report this, some won't. It's not universally used. It's used in some risk calculators, but if you see it on there, you can ask about it and how it factors into your treatment plan. But don't be worried if you don't see it in there. Not all pathologists and oncologists will use it. Gene expression panels, probably the most widely used, and in fact, this is the one that's endorsed by the NCCN, the National Cancer Guidelines Commission. It's Oncotype DX, and what it looks at is it'll give a score. After surgery, we can submit a portion of the tumor to the lab. They look at several genes and come up with a score of how likely is it that tumor will recur. It's a recurrence score. Also, it'll be given in a percentage. What's the percent likelihood that there will be a recurrence in some time frame with just aromatase inhibitors or tamoxifen alone, no chemotherapy, or what benefit does chemotherapy add to the prognosis of that patient. And this is generally done for ER positive tumors that are node negative, but more and more often we are doing them on node positive tumors. And this is a great tool that oncologists will use when they have a discussion with patients about whether they think a patient will need additional chemotherapy after surgery or not. Definitely something to look for. It often will not be in the path report early on because this is a test that's done later. It takes a few weeks to do, so you may see it addended to the original pathology report, or you may see it just separately in the medical record. But you should definitely have access to this. And as I mentioned, the law is that you can now have access to your full medical record. If you'd like to see if you had that, you should definitely ask for it and look for it. It's usually several pages long. Here's one of the other pages where they'll just demonstrate graphically that number, whether without treatment and then with treatment, how does the risk of recurrence over time change. Neoadjuvant, I mentioned this a couple of times, and what that means is somebody going to be treated with chemotherapy and or radiation before surgery? For instance, somebody may be diagnosed with a tumor that, if we've looked at all of these pathology features that I've discussed, may predict a aggressive tumor. It may be very large. It may be difficult to surgically get out with clear margins, and the team may feel this would be amenable to treating first, then going for surgery. So we may see a lumpectomy or even a mastectomy, in which case the patient had chemotherapy after they were diagnosed. So what we're looking for here is, how well did the chemotherapy do its job? Is the tumor still present? Does it look like it's still viable and dividing and proliferating? Or did the chemotherapy have some effect? And if so, how much of an effect? This is a low power shot, meaning it's at very low magnification, and it's showing a complete absence of residual tumor. And this is one of the best case scenarios. If there was a very poorly differentiated tumor and the patient was given some chemotherapy before surgery, and they could feel that tumor shrinking through the cycles of chemotherapy and week after week, and sort of hoping that that was translating to a microscopic response as well. That's what it looks like. This is completely dead tumor. It's scar tissue where tumor was. If we look at higher power view, this is a different case now. This is a case where there's some residual tumor cells, and in contrast, if you remember how I started the presentation out, where there were a lot of tumor cells, this would be characterized as a good response. There's just single cells that are distributed throughout, and we can plug these criteria into various calculators and come up with a score that the oncologist will use to determine whether the patient needs additional treatment after they've gotten chemotherapy, surgery, and now what are we going to decide? So a neoadjuvant response is something that is definitely strongly associated with improved survival. If there was a good response, one of the calculators that we use that you may see in the path report is something called the residual cancer burden, put out by MD Anderson. It's a calculator online that we will put in criteria of how much tumor is left, how much is invasive, how much is in situ, the size of the tumor, and we'll come up with a score. And that's prognostic in cancer at both 5 and 10 years, and it's widely used by clinicians, by the care team. The one last criteria that I want to look at, this is sort of an evolving area, not widely reported, not accepted yet in all the treatment guidelines, is tumor infiltrating lymphocytes. And what that is now with immunotherapy being successful in other cancers, notably lung, where we can manipulate the body's own lymphatic defense system to battle cancer. Here is a cancer. Cancer is the lighter, paler areas here, and the starker areas are lymphocytes. This is the patient's own lymphocytes, and if we saw this tumor, we would say this is associated with a high number of tumor infiltrating lymphocytes. And the thought is that that potentially translates into this particular patient. Lymphocytes are trying to contain this tumor, trying to battle it. They recognize it as foreign, trying to keep it in check. So there must be something unique among these lymphocytes that perhaps we can tweak and leverage into a therapy that could potentially be helpful to the patient. This is in contrast to a tumor below here, where we've got streams and cords of tumor cells, some as little nests and lumen here, but very little lymphatic response. Not, as I mentioned, not often reported, and it's not widely accepted yet. The last thing I want to talk about is if we were to diagnose a patient with metastatic disease or a patient who had cancer and then it's come back, that's the M of the stage. So we've gone through what the T was, what the N for node, and what M for distant metastasis. Either it's presence of a metastasis or it's not. Then when we take all those three criteria, the T, the N, and the M, and we have an individual score for each one, we can then group those into what's called a clinical stage here. And this is something many of you may be familiar with from pathology reports, from friends and family that may have had cancers, is you'll hear, oh, it was stage 3A or 2A or stage 4, and that comes from this table. So a stage 4 cancer would be any T, any N. If it has a metastasis, it's automatically a stage 4. So you can see why metastasis, the presence or absence, is one of the key drivers for prognosis and prediction among breast cancer. Once we can rule out a metastasis, then we can put it into one of these other categories, and that's delineated by the size of the tumor and also the presence or absence of nodal involvement. Each one of those stage carries differing survival statistics, differing potential treatments. Metastatic cancer, some of the things you may hear about that are sort of evolving. Actually, testing for BRCA, often done in many patients up front after a new diagnosis, or if there's a strong family history. And the reason why we test for that is because that can open up some treatment therapies, what we call PARP inhibitors. PARP inhibitors are potentially useful in BRCA positive patients who have metastatic disease. There's other markers that we may look for and stain and report in a path report. PD-L1, that would generally be reserved for cancers that are what we call triple negative, that are ER, PR, HER2 negative, and that's trying to utilize the immune system, leveraging the capacity of the immune system to attack the tumor that I showed in that tumor infiltrating lymphs. HER2, we definitely retest all metastatic tumors for ER, PR, HER2. They can sometimes change their signature when they recur or spread, opens up options for different treatment. Just real quickly about BRCA, the reason why it's so important. BRCA is a normal molecule in the body that normally repairs DNA. It normally will repair DNA that is broken on both strands. As you recall, DNA is double-stranded. And the way we can utilize it is that tumors, if they're BRCA mutated, often cannot repair double breaks in their DNA. What we can do is then use a PARP inhibitor to make sure they can't repair a single break either. So if they can't repair any breaks, that tumor hopefully will go through what's called synthetic lethality, lead to DNA damage and cell death. That's why BRCA is useful to know, because it opens up this possibility of using a PARP inhibitor. It doesn't have any effect on normal tissue, because normal tissue will have non-mutated BRCA that can, even if you give a PARP inhibitor to prevent DNA repair on a single strand, an intact BRCA can still repair that DNA, so the normal cells will survive. Tumor cells will hopefully die. I want to spend the last 2 minutes just briefly talking about COVID. Since the last time I did this, the world has gone through quite a time and is still evolving, and yet to determine what the true impact of COVID has been. But we are definitely seeing more cancers. I think a lot of it is due to missed surveillance, missed screenings, missed mammogram appointments, missed colonoscopies, missed pap smears. We're just now getting a handle of it. Here's a abstract that was presented at the ASCO meeting just recently in the fall, the impact of COVID on breast cancer stage at diagnosis. And the bottom line here was that patients were more likely to be diagnosed with late stage breast cancer following the global shutdown due to COVID. This is something we're keeping a close eye on, and why you're hear all of these calls from doctors to please come back. Don't forget your routine screenings. And that's something I definitely want to end on here, is to make sure you come back to the hospital safe. We want to make sure that you stay healthy and are in the current protocol for screenings, not just mammograms, but other cancer-specific screenings like colonoscopy, pap smears, PSA, other things like that. I'd just like to acknowledge a couple of websites that are very helpful that pathologists use all the time. One's Path Presenter. It has images. I've used that to download a few of the images, and Path Outlines. It's very helpful. Any questions? I'll take the last 5 minutes here with some questions.
Okay, we've got a couple of questions. One is regarding the features you discussed. Are they based on the biopsy or on subsequent lumpectomy? And related to that, do the features tend to change over time?
That's a great question. We will make those determinations on both the biopsy and the subsequent excision, whether that's a lumpectomy or mastectomy. We will score them independently of each other, but more times than not, they do match up. So the score, the grade that we call on a biopsy is often what we see in the resection, but not always. Sometimes tumors may be scored more poorly differentiated on the excision, because as you can imagine, a biopsy is just potentially one piece of a larger tumor. So there could be more to uncover there. So yes, they can change. Good question. Okay,
another one. Are there other gene expression panels besides the Oncotype DX?
Yes, Oncotype DX, the one we talked about, is the one that's most commonly used. It's been validated. It's in the National Comprehensive Cancer Network guidelines to make decisions, but there are other ones you may hear about. One's called MammaPrint. It's used commonly in Europe, less so in the States here. There's another one called Prosigna, and also EndoPredict. So there are a variety of them out there, but the 21 gene panel, which is synonymous for Oncotype, is the one that's most commonly used.
Okay, we have just a couple more minutes, so I'll ask the last two questions together. Regarding metastases, how does a pathologist determine whether they are from the breast or another organ? And the last would be, can patients actually talk to a pathologist, and would that even make any sense?
Great questions. I'm passionate about the last question, so I'll save that one for the most. Regarding METs, that's one of the challenges as a pathologist, is I may see a tumor under the microscope, not know where it's coming from. I can use a variety of stains to determine what the tissue of origin is. So if I had an unknown tumor that was in the liver that got biopsied, I might do an estrogen stain and say, this is positive, it's likely coming from the breast. And I have a variety of stains like that that I can use to say that something's coming from the lung or the GI tract, the breast or the prostate, and that's something that we constantly are updating and using to try and hone our skills there to make better and better diagnoses. Regarding talking to a pathologist, definitely you can talk to a pathologist. I would say ask your oncologist if it's available at your institution. I know here at Newton Wellesley, we have a program where we will encourage patients to come and see their tumor under the microscope and sit down with the pathologist and go through some of these features that I just outlined in this past hour and what it looks like in your particular case, what the tumor looks like under the microscope, As I mentioned, I think the best patient is an informed, educated patient, and what better way to become informed than to see what the pathologist is seeing.
Okay, great. Well, on behalf of the entire Massachusetts Breast Cancer Coalition, the board, myself, Cheryl Osimo, our executive director, I'd like to thank you, Dr. Misulak, for this super helpful discussion. And I hope you'll come back and join us next year again, because everybody wants to hear what's new. I'd like to thank everybody who joined in today. For those interested, the recording of this webinar will be on the mbcc.org website later today. That's pretty simple, mbcc.org. Thank you all, and I'm wishing you a very wonderful afternoon.
Great. Thank you, everybody.
Bye-bye.
Bye.